The core focus of our study was finding a way to streamline care for children with Kawasaki disease so that they can safely spend less time in hospital. We aim to do this by creating a standardized clinical pathway for patients with Kawasaki disease that encompassed admission to discharge. So Kawasaki disease is an acute condition, meaning of sudden onset, causing fevers and inflammation of blood vessels. And it's actually the leading cause of acquired pediatric heart disease worldwide. So this project addresses a major priority because at the center where the project was conducted, there were approximately 100 admissions per year for this condition. And on top of that, our pediatric inpatient units were operating consistently over 100% capacity. Furthermore, Kawasaki disease admissions are incredibly resource intensive on our healthcare professionals and our healthcare system. KD, or Kawasaki disease, costs over 6 times more to treat compared to other causes of acute pediatric admissions. And one of the drivers of this increased cost is prolonged hospitalization, awaiting tests, and subspecialty consultation. And then more importantly, for families, a diagnosis of KD is often a sudden and distressing experience. This is often the patient's first encounter with the healthcare system, where they have to stay in an unfamiliar environment while being subjected to frequent tests and treatments. Families affected by KD report significantly more anxiety and lower quality of life within the first year after diagnosis compared to other pediatric admissions such as bronchiolitis or pneumonia. And much of this anxiety and worry was attributed to a lack of clear disease-specific information. So in this project, our goal was to not only make the system more efficient, but to also improve the experience for families by giving them better resources and a clearer path to going home. So we hoped that by publishing our clinical pathway and the rationale behind the development, other centers would be able to adapt the pathway to suit their workflow and local context to help improve patient experience and reduce the burden of inpatient admissions. So the project was successful in that we achieved a 17% reduction in the average length of stay, bringing it down from about 55 to 46 hours over the course of 1 year of intervention. So while our team originally aimed for a bigger drop, this 17% reduction was sustained and saved about an estimated $25,000 over 49 admissions. These savings come from both the shorter length of stay and from eliminating unnecessary blood tests. Other interventions included streamlining the echocardiography booking process, developing a discharge checklist, requiring patients to be fever-free for only about 24 hours prior to discharge, standardizing discharge instructions, and improving patient educational resources. So our interventions were developed in collaboration with volunteers from Kawasaki Disease Canada, which is the patient organization that advocates for families affected by KD and provides support for those who are newly diagnosed. They helped us develop this guidance with regards to expected symptoms following discharge, when to return to care, and when their child can return to activity. These are all common questions that can cause confusion and anxiety if not clarified ahead of time. The other major finding in our study was that there were no safety concerns. So none of the patients with normal initial heart scans developed any new aneurysms after discharge, and there weren't any cases of missed fevers between discharge and their first clinic follow-up. Furthermore, the earlier discharge did not result in increased access to emergency department care post-discharge. And lastly, caregiver satisfaction remained high and comparable to caregiver satisfaction across the hospital. Families felt like they were getting comprehensive medical information and they felt more prepared for the follow-up process. And it really showed that we can make these bold practice changes like shortening the admission and reducing blood work without putting children's safety at risk.